Okay, so our systematic review was on the effects of aquatic therapy on patients who have undergone total hip or total knee arthroplasty, and it was done by myself, Jeff Miller, Greg Specka, Holly Woodcock, and with the help of Dr. Peter Leininger. I just want to go a little bit into the background and prevalence of total joint replacements. So as you can see, there are over 719,000 total knee replacements done and over 332,000 total hip replacements done in the U.S. per year, and that number is increasing every single year. And there are some contributing factors to that, and they include not only aging population, desire of younger patients that you'll see wanting to stay more physically active, and the expanding indications for these procedures. However, there is a lack of consensus regarding the post-op treatment, and there's not a lot of research or knowledge out there on the maintenance of the training-induced effects that these patients receive through physical therapy. There are a lot of advantages of aquatic PT compared to land-based PT, and here are just a few of them. So for example, immersion, it relieves the body weight and reduces the joint compressive forces. The hydrostatic pressure increases security, and it also decreases lower limb swelling. You're going to have increased blood flow, and that'll aid in healing, and the warm temperatures usually contribute to pain relief for these patients. Okay, so there is a difference between aquatic exercise and aquatic therapy. So for example, aquatic therapy needs to be done by a skilled PT or PTA, and they obviously use their skilled clinical decision-making and evidence-based practice, and all the studies that we looked at had the skilled service of a PT. Through looking through our research, we found that there are different water temperatures based on the pathology that the patient has. So as you can see, you would like colder temperatures for more active patients, a moderate temperature for less active patients and those with arthritis, and warmer temperatures for patients who have spasticity issues. Okay, the evidence has shown that aquatic interventions help in both functional activities and a bunch of impairments. And these are just to name a few: aerobic capacity, balance, body mechanics, flexibility, relaxation, and muscle strength. So therefore, the purpose of our systematic review was to evaluate the efficacy of aquatic therapy as an intervention for patients who have undergone total hip or total knee arthroplasty. And Jeff will go over the method section.
Alrighty, so for the methods, the search engines we use were Medline, PubMed, ProQuest, CINAHL, Google Scholar, and we also use the APTA Aquatic Physical Therapy section. The terms we used were aquatic therapy, hydrotherapy, total joint arthroplasty, or total joint replacement, and our limits were they had to be peer-reviewed scholarly journals, they had to be humans, and it had to be between January 2000 and April 2014. So our inclusion criteria, they had to be randomized control trials, and the patient had to have undergone a total hip or total knee arthroplasty and subsequently received aquatic therapy or were part of a control group. And our exclusion criteria were patients who had undergone a hemiarthroplasty or a partial arthroplasty of the hip or the knee, patients with neurological conditions or impairments, and patients with contraindications for aquatic physical therapy. And some contraindications would be open wounds, uncontrolled seizures or diabetes, or acute joint inflammation such as RA. Alrighty, so here's our Prisma. From the 5 databases that we searched, we found 2,702 articles. Out of those, we removed 2,696 articles due to duplicates or due to our inclusion and exclusion criteria, and the majority of these were removed because they weren't randomized control trials. So that left 6 articles that we identified for our systematic review. Alrighty, so here's our scoring for our articles. The PageRank scores ranged from 5 to 8, and the average score was 6.8. And as I said, all of them were randomized control trials. Here's our PageRank scores. And the most commonly deducted item from the PageRank scoring was lack of blinding of the subjects and lack of blinding of the therapist who administered the therapy. So Holly will take over for results.
Okay, so the total number of participants in all of the studies was 523. There were 337 with total knee arthroplasty and 235 with total hip arthroplasty. This chart indicates the onset date of therapy following surgery and the duration of treatment. The onset ranged from 3 days to 18 months, and the average length of duration for treatment was 6.2 weeks. Next, we examined the outcome measures used in each study, and as you can see, 5 out of 6 of our studies use the WOMAC as one of their outcomes, and this assesses physical function, pain, and stiffness. So the first area that we examined was comparing land to aquatic PT, and this study only looked at patients with total knee arthroplasty. And what they found was that stair climbing power improved up to 26 weeks post-op, and the aquatic group improved greater than land PT. The WOMAC function score showed greater improvement in the aquatic PT group. There was a greater reduction in knee edema, and there was a greater increase in knee flexion range of motion following 12 visits when compared to land PT only. Next, we examined the comparison of initiating aquatic PT early versus late following surgery. Early PT started post-op day 6 with a waterproof dressing covering the wound, and late PT began post-op day 14. The results of this showed that for patients with TKA, it was found that all mean WOMAC subscales were better in the early aquatic therapy group when they measured at 3, 6, 12, and 24 months. And conversely, for THA, all mean WOMAC subscales during follow-ups were better in the group starting aquatic therapy late versus early following wound healing. Next, we found overall aquatic PT has also been shown to improve the following areas. Hip abductor strength was significantly greater at day 14 of treatment compared to land PT only. Knee extensor power increased by 32% following intervention, and this was measured by an isokinetic dynamometer. Knee flexion power improved by 48%. There was a small but significant increase in thigh muscle cross-sectional area of 3% following aquatic PT. There was also a 9% increase in habitual walking speed, and stair ascending time decreased significantly by 15%. And for the TUG and PSFS, there was no statistically significant difference, but the relative difference in scores on the two outcome measures suggests that there may be a clinically important difference. And finally, we looked at the long-term effects of aquatic PT, and as evidenced by the table, the area highlighted in red, you can see that after a 12-month follow-up, the training effects remained in knee extensor and knee flexor power. And now we will go through the clinical relevance and conclusion.
All right, so let's talk a little bit about what this means for us as clinicians. So based on the studies that we reviewed, we determined that aquatic physical therapy is an effective treatment for patients who have undergone either a total hip or total knee arthroplasty. So for the clinicians out there, if you come across these sort of patients, we would strongly advocate that you either use this as a treatment or just part of an eclectic approach if you feel that that they could benefit from the benefits that Gary spoke of earlier, the reduction in swelling, improved blood flow, and the unweighting of the joint, provided that you have the equipment. The WOMAC was used as an outcome measure in 5 out of the 6 studies examined, as Holly said earlier. All right. Aquatic physical therapy has been shown to be a more appropriate intervention than traditional land physical therapy for some patients who have undergone a total knee arthroplasty. Total knee arthroplasty patients have been shown to have better outcomes with aquatic physical therapy in the earlier stages of rehab, whereas total hip arthroplasty patients have been shown to have better outcomes in the later stages of rehab. And as evidenced by our follow-up study, long-term benefits of strength can be maintained as long as 12 months. So some of the limitations that we found with this review was that there was no consistent or standard outcome measure for each randomized control trial, and that there were various topics reviewed. And these two things made it very difficult for us to put the studies side by side and compare them. While it is great to have a very umbrella of topics reviewed, such as early versus late aquatic PT, land versus aquatic PT, and long-term outcomes, it would have been nice to have a few studies in each category so that we could have compared them. Also, there were a larger number of patients with total knee arthroplasties than total hip arthroplasties. There was no standard protocol between studies, no uniform length of study, and a lack of program uniformity concerning the frequency and duration of the intervention. So, in the future, we'd like to see more studies with patients who have undergone total hip arthroplasties. We'd also just like to see more studies in general, specifically randomized control trials. And obviously with the randomized control trials, we always want to do better, increased sample size and more robust studies. We would have loved to see a comparison of aquatic therapy to other forms of treatment, like Gary discussed earlier, aquatic exercise or some sort of swim aerobics. Monitoring a home exercise program either during an intervention period or follow up and see how the effects are maintained. We'd also like to look at patients with joint revisions or bilateral joint arthroplasty, obviously more common in knees. And we'd love to see more specificity in treatment protocols, such as water temperature, water depth, specific exercises performed, and length of treatment. So to sum this up, we identified 6 randomized controlled trials after extensive search of scholarly articles to find that aquatic therapy has been shown to be an effective treatment in patients with either total hip or total knee arthroplasties. Lack of uniformity between these studies regarding outcome measures and treatment protocols complicated the comparison. And in the future, more uniformity and more robust, high-quality randomized controlled trials would be beneficial. We would like to extend a special thank you to our faculty advisor, Dr. Peter Leininger, as well as Dr. Sanko, Dr. Golden, Dr. Sung, and Dr. Ross, all of whom contributed to this presentation.